he has comorbidities, physiological changes, and there are certain consequences. So as far as hypertension as a comorbidity is concerned, there's more vascular resistance, and hypovolemic state is masks. Coronary artery disease, there's less chronotropic reserve and less contractility, so heart rate responses may be slower, and that may also be the case because of certain medical conditions or medication that the patient is on for his heart disease. Renal insufficiency of GFR goes down. There's a higher risk of fluid overload. Chronic pulmonary disease, you have altered drug metabolism and a higher risk of ARDS. And diabetes, of course, is an issue. And so because of these issues, you have a different response to hypoxia and higher risk of infection, especially local infections. And so all these issues play a role. What we have done recently, we have implemented new standard operating procedures for geriatric trauma patients because they are so different. So now let's go to our case. It is a true case that we are currently treating in our unit. So here's a 74-year-old male. He was walking downtown, which is about 5 minutes away from the hospital only. So very short rescue time, which may play a role in this case. So the paramedics were called, and they went through the ABCDE of ATLS. Airway was free, C-spine was immobilized. There were some issues with respiration sound, so a puncture was done. He was unstable, needed catecholamines, and a pelvic binder was placed. So most of our cases come in with pelvic binders anyway. And then he had pretty much altered mental state, which is why he was intubated. So then, as I said, quick rescue time, and he came to us. This is the primary survey that we have here. An intubated patient, saturation pretty good, chest wall appeared to be stable. He is in shock. He also has an obvious femur fracture on the left, and then you cannot assess further issues right away, but he's also becoming hypothermic. And so here comes the first poll question. I wasn't sure if somebody wants to take over.
So what are you going to order now for your diagnostic investigations? Would you go for a chest X-ray, pelvic X-ray, and C-spine X-ray, whole body CT scan with contrast, whole body CT scan without contrast, a CT scan combined with some regular X-rays, or something completely different? Okay, and about half of us would go for a whole body CT scan with contrast. Interestingly, the second popular option is other. So look forward to finding out what that means.
Well, exactly. We should probably keep it in mind because the reason why we added with or without contrast is because you wanted you may be considering to protect renal failure issues in the geriatric patient, and therefore leave out the contrast. But so currently, at least at our place, there is no altered concept for this sort of patient. So they do get contrast, which may or may not be a good idea, I don't know. But let's see what's going on. So here's the summary of the diagnosis. So CT scan was done. You can see there's a non-displaced fracture of the C-spine, subtrope fracture on the left-hand side, some bleeding here in the frontal part of the cortex. He has a pneumothorax, of course, and here's another spine injury, which is a distraction injury. There's also a tibial shaft fracture, a segmental fracture. The knee prosthesis in place appeared to be not a particular problem, and then the non-displaced C2 fracture is also obviously not a big problem. So here is the summary of the diagnosis: severe brain injury, intracranial bleeding, pneumothorax. There are some fractures of the rib, although the first survey appeared to support the idea that the rib cage was stable. So Anderson type 3 fracture, unstable T10 fracture, subtrochanterior femur, and tibial fracture on the right. And then we also got the lab. The ROTEM is okay. INR 1.4. We looked at the temperature before. You can see that hemoglobin is rather low already, despite the short rescue time. Catecholamines are given, and as far as these 4 cycles go, the tissue injury seems to be substantial. Now comes the next question. How would you categorize this patient?
So would we say he was stable, borderline, which is an interesting concept, unstable, in extremis, or something else? Okay, well, not unsurprisingly, nobody thought he was stable, and the vast majority would say that he was unstable. Chris, perhaps you'd like to explain what borderline means.
Okay, well, borderline means that
sorry, I should have shared those.
You cannot say completely what the problem is, and I think it is an issue that is more important in younger patients that have a lot of physiological reserve. I think this patient is you can have to classify him as unstable because he's already on catecholamines and he's still in shock. The ones that if you are uncertain and then they respond, those are the ones that we have classified as borderline previously, and I think categorizing him as an unstable patient was a good idea here.
May I comment a little bit, or if I go back to the first poll question, I was one of the ones answering other. In my mind, this guy is in no way suitable for CT scan when he arrives. In my mind, he is in extremis. He has a very low blood pressure. He's an older man you have to presume that he has comorbidities. He has a GCS of 3 on scene, so he has a head injury until proven otherwise. He is in hemodynamic shock when he arrives. He needs to be resuscitated before he can go to a CT scanner. In most institutions, that will take more time than he has, basically. So I would say that this guy needs a primary survey, starting resuscitation, master transfusion protocol. Make sure that his chest puncture has not given him a tension pneumothorax. He needs his chest tube before he goes to CT scan. We should not see that pneumothorax in the CT scan, and then start to see and have a blood gas and see if he actually responds to resuscitation. And when he does, which he would have, then he is suitable for CT scan. I can get his CT scan done. In my mind, this guy should not have gone to CT scan that early. And I think that's why I answer also that he's in extremis, because his blood pressure he's probably hypertensive. He has hypertension from before. So he's really out there, and we would never give catecholamines to these patients before we've ruled out that the problem is bleeding. And obviously it has been thought that bleeding was a problem because he had a binder on. So someone has thought that he has bleeding. So in my mind, then catecholamines should not be there before we have actually given him back what he has lost, i.e. blood products.
I think Tina has a very important point, but I think it will be, it depends on the infrastructure of your hospital. If you have a CT scan, a sliding gantry in the shock room, it's different with a situation that you have to transport the patient 10 minutes to a CT scan. But in our hospital, we also start with the X-ray of the thorax and with sonography to look what is the bleeding. But I think I learned a lot about the total body scan. In the Netherlands, we always looked to Germany and we said, oh, everyone is going through the CT scan. But I think if you have a CT scan at the in the shock room, the situation is different.
But
so it depends on.
I agree with you. I think it depends on situation, but I still think this guy is, even if you have your CT scan, I have my CT scan just one door from the shock room. He would never go to CT scan before I have done his chest X-ray or ultrasound, treated his pneumothorax, started his resuscitation, and he will get his CT scan. Even if it's in the shock room, it takes more minutes than actually doing that first workup, and he doesn't have that time. So in my mind, that goes. And in most places in Europe, you don't have the CT scan in the shock room. So I think it has to be commented on.
Thank you, Tina. I don't think anybody would disagree. Do we carry on? Chris?
Okay. So we definitely feel that this patient has a problem. And now we have to decide what to do. So so of course, this patient has had a chest tube. So I think that's not even worth mentioning because it's a routine anyway. Here's a list of issues that we can have a look at for question 3.
So would you go for early total care with fixation of the spine, femur and tibia on the first day? Would you fix the spine, the femur and the tibia all with X fixes? Would you decide to fix one long bone definitively and X fix the rest? Would you fix the spine first, or would you do something else?
Before voting, do you hear me?
Yes.
Before voting, we need another information about the blood pressure and heart rate. So probably at least 30 minutes is now left from the time of the admission. Is the patient still hypotensive or not?
Yeah, so that's a very good question, and I can tell you that the mass transfusion protocol was used, and so this patient actually responded more adequately than we thought, and the operating room is pretty much next door, and so within about 20 minutes or so, he was improving.
Now we can vote.
I think most people have voted already, and what they have decided, and a third of the audience have decided to fix everything with X fixes, or at least to X fix the spine, the femur, and the tibia. Second most popular option is to do something other. Be interesting to see what that is.
Yeah, that's going to be interesting. So maybe we can advocate everybody that has voted other. Maybe you want to put something in the chat or give us some information what you will do. I guess what we have not covered with this list of questions is if you use traction only or you splint the tibia or something, which obviously would be the rule in most places in North America. So they just splint these patients and they shift them to the ICU or a lot of times.
May I, a short comment? With others, I don't vote for it because I can't vote, but with others, I mean, look for the source of bleeding. This patient is for me obviously in in shock. I don't know what the last blood pressure and so on is, but for me, this patient is still in shock, or isn't he?
Well, he improved. He received the chest tube. He received some lines, and I said before that within 20 minutes or so he improved, and then he could go to whatever needs to be done. So Tina.
I know there is a place for early total care, and you have this early window and when it's possible. But this guy, I would have liked to see his first blood gas, and I'm sure it's not very nice. And then after his resuscitation, you said master transfusion protocol. How much did he get before he actually normalized, like you said? And I would say that this guy, he has had a real hit. I would let him see where to actually wait until his blood gases have normalized and see that he actually remains okay before I would do anything surgically to him. And that would be, if I had to do something surgically early, that would have been damage control. And then after that, obviously, it's risky to wait too long, because that window for fixing or for fixating fractures is obviously early and would benefit him. But I think that, the reason why many have voted others like me is the fact that before you hadn't given the information about the hemodynamics. Some of these actually normalize quickly, and some of them don't. But it's about total perfusion of the body, in my mind.
Yeah, I think your point is well taken. And when going through the case and having seen this patient, I was really surprised how quickly he improved. And the more I thought about it while preparing this case for our presentation, I felt that this is kind of unusual. And I think we have to, you have to say that in the geriatric population, because of the rigidity of the chest wall, 6 fractures of the ribs, they will puncture your and cause the pneumothorax, but it doesn't really mean that functionally the lung is completely out. But you mentioned this issue, and this is going to be a major issue to discuss within the next few minutes. So let's go on. Because at this stage, we get additional information by his wife. So he had a COVID-19 infection since 13 days. And the day when he was walking around was actually his one of his first couple of days after being released to the public. She told us that he has arterial hypertension. She doesn't know what kind of treatment he gets. She tells us that he's on aspirin, probably because of cardiovascular problems, but she's not sure. He has a bilateral total knee. That's something we knew. He suffers from chronic back pain anyway, and he is anemic in the first place. So that's could be, it doesn't have to be, but it could be a game changer. What we have done during the first wave is we have changed our guidelines for the patients that we know are COVID positive, and try to limit contact. Just a little bit of some information. So let's get to the poll question number 4, which I think is really interesting these days. Jonathan?
Okay, so does the fact that this patient has recently been diagnosed as being COVID positive change your strategy? Would it make you less aggressive? Would it make you more aggressive in your treatment, not as a personality trait? Would it make no difference to your management of the patient, but you take more, you'd use more protective equipment for yourself, or would it make no difference at all? Or would you go for the other option? Okay, so interestingly, almost 80%, it would make no difference to the management of the patient, but you just make sure that you had proper personal protective equipment. and that is the overwhelming decision.
Okay. Well, I would like to mention one more issue and maybe stimulate the discussion a little bit, because this patient, he was 14 days out and he was officially released to walk around in the city. And so I don't know what the other panelists are thinking, but does this patient actually need protection, or can we be on the safe side, or what do the panelists think?
In our hospital, we are following some rules. If the patients come in, then we get a COVID test, and until we get the results, we will protect ourselves the same way as with the COVID patient.
Exactly. I think this is a very good comment, because we had the same situation. So here is the infectious disease guy telling us that we don't have to protect ourselves, while everybody. So he had the COVID test, which one of these fast tests that came in, and he was positive still. And the infectious disease guy tells us, all right, that's no problem, because it's just the remnants of the previous infection. You can still see it, but he's not infectious as such. And so what do you think about that?
May I say? You hear me?
Of course.
Yeah. In Slovenia, in Slovenian Society of Surgeons, we decided and we published in Slovenian paper that all polytrauma patients at admission are treated as they would be a COVID positive until we prove that they are negative. So we all of them admit to the urgent center for the COVID patients, and we start resuscitation in the shock room on the CTA machine, and after that, and we all use our personal equipment against the infection. And in the meantime, after a couple of hours, we get this PCR test, and after that we decide whether the patient from the OR should be sent to the
Okay, so I can tell you what we have done, because obviously for the surgery we didn't have the results yet, but it only came afterwards. But in the meantime, there was this big discussion going on, and then eventually the ICU guys said, because we have an ICU only for COVID patients, they said, all right, in order to be on the safe side, we will just put him on this COVID ICU. So this is basically what happened, and everybody protected.
May I comment? May I comment? We do it the same way as Klaus said. A patient is positive until he's proved negative, but we had the possibility to make the tests by far faster. So we have now a PCR test. Usually you have the result within 1.5 hours. So this does mean when the decision is to get him to the ICU, you know which ICU you can take, positive or negative. I think this is a quite important thing, and it works. It works only for emergency patients to have it in this short time, but it works.
Yeah, I think we do exactly the same as well. I think, but I think we have to do. I mean, there is a screening of those. This patient obviously has been positive, and he might still be positive. And nobody, I think, everybody agrees that protecting yourself is not a bad thing, or it should be done maybe in this patient. But we have a screening. We don't use protective equipment for the whole team for every single trauma patient, because that would use a lot of potentially limited resources, especially did so in the beginning. So they had to be screened and then they are getting their tests, and if they were to be put in isolation, then they get the rapid test. But I think it's important to the point that most people have answered no, just protect myself. I think what happened early during COVID was that because of fear, we delayed treatment in many of these patients, or did give them different treatment than we would do normally. And I think it's nice that we are getting to a point where people actually go back to treating patients for what they come to hospital.
Okay, Chris, do you want to carry on?
Okay, of course. So let's focus a little bit on the brain injury, which we haven't done so far. Of course, non-surgical treatment is the option here, and prevention of coagulopathy was put down by our neurosurgical team, we also the chest drain on the left side. And all these issues have been the case. What I didn't show you initially is the X-ray of the position and the successful drainage, and the pneumothorax wasn't even that bad. And the other issue is you can see the signs of the COVID infection right here. And the other issue is that hemothorax wasn't really severe. And so this patient, C-spine was immobilized, then external fixation was done on admission with the damage control technique. For the tibia, we were kind of worried because of the soft tissues of the tibia. And you can see the subtroch fracture. It was put in like this. And then we have some data for on the next day where the INR is okay. Temperature obviously has normalized by far. Here's some issue because the hemoglobin is still not great. And for some reason there's some increase in the lactate, which if you remember, it was about 2 initially. You have the brain injury issue and the chest trauma issue. So on the second day, definitive fixation of the femur was done, where most of the factors had normalized. And here is just a little bit some notification of some work that we have done. We have compared the outcome of geriatric versus non-geriatric severely injured patients. And interestingly, what we found is that if you compare patients below the age of 70 and above the age of 70, there was no statistical difference in the mortality rate. But interestingly, there were some issues of the complication rates, so that was significant. And then if you look at the types of complications, it is interesting how anemia, pneumonia, urinary tract infection, myocardial infarction, and then all these geriatric specifics like delirium and stuff like that, renal failure, wound infection, this was the big difference between those patients. And so apparently it may have to do with the rescue system in Western societies, or we don't exactly know, but I just wanted to share this information with you. And so what we did, we waited to do the tibia until day 4. And because of the total knees here and the segmental fracture, which is here and there, we decided to do double plating with subcutaneous plate fixation. So maybe somebody from the musculoskeletal section can comment on it. But we felt that we are unable to insert a nail in this patient, in this type of situation where the knee prosthesis is in place, short proximal segment, and this is what was done. Richard, did you want to comment on it? You're still in
Yes, it's a quite good solution. In my percutaneous stabilization is good. You need 2 plates in this case. So although this is a typical Swiss solution, I think it's quite okay, definitely.
What would be the Vienna solution? What do you do in Austria? Just a single plate, I guess.
Maybe we would do a single plate, yeah, maybe. But I think this is just depending on which type of plate you use, and do you have a long plate enough to fix everything with 1 plate? So I don't think this is the question. This is just depending on your personal experiences and materials you have.
Sorry, my question, Chris. May I ask? I didn't hear good. On the day of admission, what did you do with the proximal?
Well, the proximal, it was just an X-fix everywhere, external fixation.
External fixation also for the subtrochanteric fracture?
Yes.
Okay.
I didn't show the X-rays.
And what you did with the lumbar spine?
Exactly. We didn't do anything with exactly. And so that's going to be one point of discussion, because you may argue, well, why do they stabilize the extremities before fixing the spine? And we can get to that a little later. Because here comes another surprise. So the chest is taken care of, the proximal femur and the tibia are taken care of. This issue is unsolved, and we had posted this patient for last Friday for fixation of the spine. And before that, they tried to wake him up on the ICU because he was extubated in the meantime. And then he didn't wake up. And the issue was that there was additional hemorrhage going on in the brain. And so the ICU team decided that the spine shouldn't be done Friday. And they had to wait until just a couple of days. So basically, I can show you what we did this morning. So this morning, it was possible to do this spine fixation. You can see cemented screws, segment augmentation, and so this is what was done. So I think this pretty much sums up the case. I think the timing of the spine fixation can be a real issue to discuss, because you had to transport the patient back and forth several times. And yes, so maybe you want to take over again for the discussion.
Sorry, may I ask again if you hear me?
Mm-hmm.
Jonathan, may I?
Yes, please do.
Yes, I didn't hear. What did you do on the day of admission with the proximal femur on the left side?
We did damage control. We just fixed him. So the patient came to the operating room, and he basically only treatment for the lower extremity was done. And then he was transported on the ICU for warm-up and further resuscitation.
Okay, thank you, Chris, for a very interesting case. The final question you posed there was about the stabilization of the spine. Is that something which other members of the panel would do at this late stage, or would you have done it earlier on to make it perhaps safer while you were moving the patient around and doing the other fractures?
Well, we would have done it also at very late.
Would anybody
Our spine surgeons we would have done it as soon as he tolerated, after having getting rid of the X-fix.
Exactly. I think so, because I had a really bad feeling several times, because you could have argued to do the spine first. You know, right after this patient is stable, you can even position the patient in a way where with the X-fixes on, You can put lateral X fixes, and you can position the pine on the patient in prone position. So I think you can decide either way, you know, depending on I don't know, other issues.
Well, I would.
Go on, Richard.
For, now, what I think this is what I don't see the CT scan. For me, this is a B3 the fracture of the spine with it's no better, but it's no bamboo spine, but degenerative changes. So you have to avoid hyperextension. But if the patient is at the ICU, he is safe. Only with mobilization he would be unsafe. So we would do the same. The priority was the shock. The second was long bone, and after that we would stabilize the spine, and the same way with the long distance and with augmentation. We would do it the same way as you did it.
I will also say that there's one priority there, that's the head injury. That will also decide when we are able to do what. But has it been commented the use of tranexamic acid for because the head injury showed increasing intracranial bleed after the initial resuscitation. I think there is more and more evidence coming up that in intracranial hemorrhage that tranexamic acid should be part of the treatment, early treatment.
Yeah, we have a very low threshold for using tranexamic acid, and we are also rely on it quite a bit.
Well, we use it only in single brain, in isolated brain injuries, not in polytraumas. And what I wouldn't have dared to do the spine initially. It's an old patient. He has brain injury. He has a thoracic injury. He has a severe extremities fractures. So this is a definitely unstable situation. And I wouldn't have dared to do a spine surgery at that time. No way.
Can I just make one comment? I think this is the typical patient where we actually need to be multidisciplinary and have discussions with all involved specialties, general trauma, orthopedic trauma, ICU, and so on, and decide what are the priorities and what risks are we willing to take on his behalf. What is the most important for him, and what does he tolerate from day to day?
So, excuse me, may I ask one question? Do we have time for it?
Of course.
Yes. So in the beginning, we saw this patient was hemodynamically unstable in the trauma bay, and yet hemoglobin of 8 and the need for catecholamines. The question is, what was the reason for it? We are looking back to all this, to the whole course now. So was it the extremity fractures or femoral and tibia fracture in combination with thoracic trauma? But obviously he had no trauma in the abdomen. And also in other breathing causes. So what was it? Or was it a brain injury? Are there any comments or?
Can I make one comment on that? I think what we see very regularly is if you have a really massive blunt trauma, they decompensate even if they don't have visible bleeding sources on their CT scan, because of the hit, basically the tissue injury itself. And that means they do need resuscitation with blood products, because if not, all these the potential bleeding sources will start bleeding if we don't resuscitate them with blood products. So I think the reason why he was hypotensive and in shock like that was because of just the amount of crush to his body, injury.
Yeah.
But where did the red cells go?
Exactly.
I think it's his pre-existing anemia. No, just kidding.
Another option. Okay, fantastic case, great discussion. Can we move on to your presentation, Klaus? And
yes, we can.
Excellent.
You see the presentation?
Not yet.
Not yet. Not yet. Here we go.
Do you see it?
We do now, yes, thank you.
Okay, thank you very much. So we will I will give a presentation about geriatric polytrauma Chris mentioned several topics, and I will take you with me through our research at our hospital. Geriatric trauma, polytrauma is one of our topics where we of our research topics. What do we know? We talk about it. The geriatric population is still rising. In 2014, we have about 25 to 26% of the people are older than 65, and we know that the mortality will increase too with this group of polytrauma patients if they are injured. We all learn the ATLS priorities, the ABCDE. The priorities are the same for everyone, for all patients, and we learn about the elderly and children of pregnant women. There are special populations. What means this? This is the last. This is the last slide from the ATLS. It's about physiology, decreasing function. We mentioned it earlier, and in summary, it's a reduced cardiac output, low physiological reserve of the lungs, limited response to hemodynamic instability. What Tina mentioned, even if a patient doesn't bleed, he can get unstable. And we have problems with low bone density, what means for problems for the stabilization. So we are wondering where we are talking about, what's different, how many patients we are talking about, what's the cause, what are the injuries, how severe are the injuries, what are the difference, and what can we learn from it. So we started our first research several years ago about injury mechanism, patterns, and outcomes of older polytrauma patients. It's a analysis of the Dutch trauma registry. In the Netherlands, we have a trauma registry where all patients who are admitted in a Dutch hospital are included, and we always have about 100% inclusion rate for all patients in the Netherlands who were admitted. This was a retrospective study from 5 years, 2009 to 2014. All patients from the Netherlands with an ISS of 16 or higher and older than 18 years. And the Dutch trauma registry is based on the MTOS plus, injury mechanism, admission parameters, ISS, blood pressure, and so on, and the AIS and the outcome, the Glasgow outcome score, ICU admission, and mortality. So when we have a look at this group, the first thing what we see is that we registered about 13,000 people who was younger, but even 12,000 who were older. That means that not only the young male is a polytrauma patient, but many polytrauma people in the Netherlands are older than 60, about 48%. And the difference between the older and the younger group is that in the younger group, 25% are female, but in the older group, almost 44%. It's the first difference. The mean ISS is about the same. If you look at the older group, the mean age is 75 years. That's very high, because if you look at the geriatric group of hip patients in the Netherlands, the mean age is 79. It's only 4 years younger than the group where we always know this is a geriatric disease, a geriatric trauma, the hip fracture. And here you can see that in the older groups, the amount of male patients are decreasing and the female patients are increasing. If you look at the mechanism, here you see car incidents. It's more in the younger group, motorbike, of course, and moped the same. But in the bicycle group, many people, not only in the Netherlands, have an accident with a bicycle, and even the group of the e-bike will bring this percentage higher than it was. There's no difference with pedestrian, but the next difference is fall from lower height. From 43% of the patients older than 60 was the mechanism of fall from lower height, lower than 3 meters. The ISS is not the same, and because it's a group, it's very big, it's significant, but it's not relevant. It's almost the same, about the mean and the median ISS in both groups. And even if you look at it's groups 60 to 24, or even higher, 25 to 49, or higher than 50, the difference are not so big, or there are only small differences. What about the injury patterns? If you look at the lower extremity, 18% against 11% in the older group, upper extremity 10 to 7%, but more abdominal trauma, less thorax trauma, but much more head trauma, 69%. If we look at the abbreviated injury scale, as a AIS, then you see that that in the group that in the head injury is 63% in the older group and 45% in the younger group. And what we saw with the thorax and with the abdomen is the other way around. So a big problem is head injury in the older patient. If we look at the physiology, there's no difference in the respiratory rate, no real difference in the systolic blood pressure, the reverse trauma score. But there is a difference in the Glasgow Coma scale. And this you have to remember for the later data. In the younger group, 20% have a Glasgow Coma scale of 3, the lowest one. And only 13% in the older group. So you can say, what's the problem with head injury? But only this is registered at the shock room. So the lowest Glasgow Coma scale is in the youngest group. Remember this for later. Intensive care unit. In the younger group, 62% of the patients with an ISS of 16 or higher went to the intensive care unit, and 55% in the older group. Maybe we can talk about underestimation, but we will discuss this later too. Length of stay at the ICU, there's no difference, but the 30 days mortality, there's a big difference. It's 9% in the younger group against 19% in the older group. And if you look here, what are the reasons for the mortality? You can talk, you can call it in a dark blue or purple. The group of respiratory failure, you see who older the patient is. This is the bigger reason of more reasons are the respiratory failure. And of course, you see with the main reasons of mortality still is head injury, the light blue. So what are our first lessons to learn? I think it's patients with a polytrauma older than 60 years is a big group. There's a small difference between male and female in this group. The mechanism is low energy accidents, bicycle or fall from a low height. There is important difference in the abbreviated injury scale in the head injury, and in the severity in the ISS there is no difference, but the mortality is much higher. After this study, we conducted a second study about older polytraumas, mortality and complications. Again, we are talking about an aging of our society, higher incidence of elderly involved in polytrauma, and the mortality rate of polytrauma is high. So what we want to know, what are the patterns, what are the causes of the mortality, and what are the early obtainable risk factors, and are they obtainable? This is from the Committee on Trauma from the American College of Surgeons. And here you can see the younger patients, the amount of polytrauma is decreasing, and in the older patients, it's increasing. We describe the mortality pattern of the elderly patient, causes, distribution, and associated risk factors, and the in-hospital complications. It was a retrospective single-center study, 2008 to 2016, older than 65 years, and ISF, of course, 16 or higher. We are looking at the risk factors and the complications of the Clavin-Dindo classification. If you see this, 380 patients. We know this about the female group is rising when the patients get older. There was no real difference in the AIS of these different groups in this study, but the mortality was much higher. Here you see, everyone knows this old slides from Trunky with the three peaks at the scene, the golden hour, at the shock room, and at the ICU. And we even know these two peaks are flattened within the last 30 years because I think of our better handling, better education, ATLS and so. But what we see now in the elderly group, we see a second peak. And the second peak is the peak after 4 to 7 days. And you see, who older the patients are, who more you see this second peak. If we look at the risk factors, we did it first without the ICA injury severity score, and then with the injury severity score. The reason was that the ISS will be registered later, so and otherwise the Glasgow coma scales and clotting disorders, so you have directly. But by both you see that that the age, Glasgow coma scale, clotting disorders, base excess, and the large subdural hematoma are risk factors without and with, but comorbidities, systolic blood pressure, and AIS, the 3 or higher, are not significant in the final model. And here again, not only the age, but if you look at the reasons for the second peak, this is you see it's different to the first peak, and you see here bleeding, head injury is the first peak, but the second peak after some days is respiratory failure and multiple organ failure. So we saw now a new second peak in the elderly people, what we didn't see if you looked at the whole group of polytrauma patients. And the same you can see in the classification of complications. Grade 5 is of the Clavin Dingo classification is death. And you see that respiratory failure and respiratory failure because of infection is very prominent as very severe complications that people are dying from. Our lessons to learn too. The peak for the elderly patients 1 week after trauma, mostly due to the traumatic brain injury and respiratory failure. This is what we didn't know before. And associated with a higher mortality is age, unconsciousness, clotting disorders, acidosis, and the large subdural hematoma. And respiratory failure is the leading cause of death and the late onset of death. I told you, about the ICU admission in our hospital, and this is a study from the United States, and it's about underestimation of elderly people. You see here that almost 58% of patients with a Glasgow Coma scale lower than 14 don't go to a level 1 trauma center, and even 67% with a systolic blood pressure of lower than 90 don't go to a level 1 trauma center. And it's different if the people are younger, 29% and 26%. And so on, even with brain injury, or what everyone can see as seen vagal deformity, and if you fall from a height higher than 3 meters, even then 1/5 of the patient don't go to a level 1 trauma center. So I think another lesson to learn is that we underestimate the severity of the injury in the older patient. What about resuscitation? We talk about a lot with the case. Treat first what kills first is the same, and do no further harm is the same too. But beware of aggressive fluid resuscitation because of the decreasing physiological reserves of this patient. And I think it's very, very important to start early with blood and fresh frozen plasma and platelets. But even in this, we don't know enough at this moment what are the difference with the younger population. So we have to go on with further research. Chris told us about damage control surgery, what we would do with this case. And here you see his, from his book about damage control surgery, about the parameters of clinical diagnosis, head injury, bilateral lung contusion. We always discuss this. We didn't discuss about the operation time and the multiple long bone injuries and hypothermia and clotting disorders. What he told us was about decision making. Not as the whole life you have white and black, but there's much gray. And this is what we have. I know I don't differentiate between unstable and extremist, but I differentiate between stable, borderline, and extremist. And that means here early total care and damage control surgery on the right side. But I think at this moment, experience and gut feeling is an important factor too. And we don't know where the borders are, but I think in the older patient, be aware of to do too much in the beginning. So in my personal experience, I would choose earlier in older patients damage control strategy, not in a total early care. But even if you have the big group of borderline, it stays a dynamic process. It can be that you go to you start with surgery and then you see how you have to change we have to change the treatment, and you will change from damage from early total care to damage control surgery. So at every moment there can be a switch if it's necessary. That about the initial assessment and management of this patient. But we if we talk about what's different, what is the outcome, and not the outcome what means mortality, but what means reported in a patient-reported outcome. This is not published yet, but it will be published in the next month. It's about this is a retrospective study in 3 trauma centers, and at the end we had 650 patients who were included, and we had a response rate of 57% of 360 patients. What did we ask? We go for the EQ 5D and for the short musculoskeletal function assessment. Those are well-known patient-related outcome measures. The first one is about mobility, self-care, usual activities, pain, discomfort, and depression, anxiety. And the second one has 4 subscales, and these subscales are upper, lower extremity, problems in daily activities, and mental and emotional problems. If you look at the EQ5D, we see that there is an association with age, with mobility, self-care, and usual activities. But there is no association with age, with pain and discomfort and depression and anxiety. And if you look at the SMFH, we see a sort pattern, upper, lower extremity. Of course, there's a relation with the age, but with mental and emotional problems, no significant trend for age was found. And if you see here the 4 subscales and the 5Q EQ5D, then we can talk about resilience. What do we mean with resilience? And resilience means after rehabilitation that you reach the confidence interval of age and and sex-matched peers of the general Dutch population. So you compare this with the Dutch population, and then you see that about in the younger group, about 80% will get this. Will come back to the what you compare with the Dutch population at the same age with the same sex, and you see here it's decreasing. But if you look at the lower extremity, you see here a dip at the age group of 30 to 39, and this you can see here too. And even if you look at this, you can say that people who are in the age group 60 to 69, this group is much more resilient than the younger group in the EQ5D. So we don't know what it is, but I think maybe the coping mechanism of the capacity for coping is in the group of the elderly 60 to 70 years old higher than in the group in 30 to 39. So we don't, it's not so that patients who get older are get less resilient. It's that it's a different pattern. So then even this group is very important. This group, these are the young people, 30 to 40 years, that their capacity for resilience is not so high than the elderly group. To come to conclusion, elderly polytrauma patients is a very frail group, low physiological reserves. There are different mechanisms. We have to beware of underestimation inflammation. And there is a second mortality peak after 1 week, and the main cause is respiratory failure. And the resilience, age shows not always a linear effect on patient-reported outcome. And what we still need are new strategies. The principle stays the same, the different maybe approach. The approach may be different, but if we look at the resilience, maybe we have to look at the patient-tailored rehabilitation in special age groups. Thank you very much.
Thank you, Klaus, for that very interesting presentation. Can I start the discussion by asking you a question relating to the fact that respiratory failure seems to be one of the leading causes of death, but that doesn't seem to be related to chest trauma? Is that a correct interpretation of your figures? And if so, why do you think that is?
I don't think that the relation is not the chest trauma of the chest trauma sec. The relationship is how you deal with the chest trauma. What do I mean? I mean a patient with four rib fractures and is very or not so severe lung contusion. If you admit him to the nursery ward, not to the intensive care, if you don't have a very aggressive pain management, then this patient gets worse and worse. This patient, if you look at the complication rate, pneumonia was one of the major complications of this group. So I think this patient's group needs a more aggressive approach in treatment, and that means physiotherapy, pain management, and so on. It's the same. There was a study from Utrecht. I think it's 20 years ago. They get a peak of mortality with a low AIS of his low ISS around 6 or 7. So that was a group of patients where the thorax injury was not so severe, but because of the less reserves and the not adequate treatment, people can get in bigger complications.
So this group of patients do actually have chest trauma. It's just that we're not managing it properly for this age group.
No, I think we were not aware enough. These patients, for instance, a patient is falling with a bike. He has a hip fracture, and but he is falling on his side too, and he had some rib fracture. He has some pain at the thorax, and you know this video about there's a fracture, I have to fix it. So everyone focused on the hip fracture, and the operation gets very well. Very good skilled surgeons are doing a very good hip operation. But the next day, the day after that, the saturation is decreasing. The patient has still pain, and so on. He gets from a not so severe thorax trauma to very severe pneumonia or so on.
May I ask you a question?
Please do.
Well, especially in these elderly patients, bicyclists, we often see clavicle fractures and upper and high rib fractures, and usually we tend to at least fix the clavicle very aggressively. Do you think that maybe we should get more aggressive for rib fixation in general in the elder patients?
I can't say yes or no. At this moment, about rib fixation, I think pain management is more important than a rib fixation. Maybe if you have a flail chest, okay, I think it would be an advantage to do it, but then you have to do it early. But I wouldn't say if there are 3 rib fractures, the patient has pain, so we fix it and then it would be better. So I think the most important thing is pain management. But of course, there are indications to go for rib fixation. But this is at this moment not really clear. Even if you look at the literature, it's not really clear what we have to do in this. We had a time where we said everyone has to get his ribs fixated, and after that we were a little bit more carefully. But I don't know. But I think what I think is pain management is more important than rib fixation.
I find that a lot of our patients, our elderly patients who have rib fractures, never complain of pain. You ask them if they're in pain and they deny it, and then 2 or 3 days later they develop the chest infection. Is that something which other members of the panel have identified, or is it just something unique to my own brand of local population and elderly people?
I comment on that, but definitely we see exactly the same, because they tend to be modest, and they don't want to be to trouble people around, be trouble to people around them, and so on. So they tend to not complain of pain, and I definitely see, and they're so much in pain that they end up with a pneumonia. I agree. I mean, aggressive. I so agree with Klaus. I think pain management is so much more important than rib fixation. The evidence is not conclusive in rib fixation. I'm sure that there is a subgroup that definitely benefit from it, but the average older patient with rib fractures, I think give them epidurals and be proper pain management, and that solves most of the problems without the complications after surgery.
Yes, because the aim is that we should verticalize them. Doesn't matter with the osteosynthesis of the ribs or not. Pain treatment and verticalization. This should be the aim.
Okay, Chris, do you want to comment on this?
Well, I thought that I can just echo both of you because the modesty of these patients is incredible. And I think they don't recognize when they have to gasp for air, you know. Yes, it needs to be focused, and we really don't know what the true indication for rib fixation might be.
So in our hospital, there is a huge aim to reduce infection rates. One aim is to reduce it below 5% rate. And what our geriatrician do is to reduce more infection rates or pneumonia rates, is to also, besides the before mentioned strategies to mobilize the patient and breathing therapy and pain therapy, they also wash out the mouth every day with special antibiotic solutions. And seems to work according to our geriatricians, that they breathe, wash the teeth and so on. The hygiene in the mouth seems to be very important according to our nurses and geriatricians in our hospital. Just a small comment to the strategy.
I think there's the basis of a study there, isn't there? Anybody else in the panel have something that they want to contribute at this point?
Can I make one comment?
Please.
I think so. I think Klaus made all the good points about. This is one of my pet topics because I think we manage old trauma patients badly, because it's more sexy to treat a 17-year-old than an 85-year-old. And so we underestimate, but we also tend to down prioritize them. And what you see is, so the literature is saying quite clearly that a big part of these patients, and that's what you show as well, they are able to get back to a normal or at the same function as they had before. But that should be the aim. Some of these the oldest patients, I think there's a dichotomy that we have to be really aggressive in the beginning with these patients if they should have a chance at all. And what we see again and again and again is that the system in the hospitals have a tendency to down prioritize or be lazy about them or not give them the proper care. And they have to be more aggressive because the 17-year-old will survive all of that, but the 85-year-old doesn't. So that's on the one side. But on the other side, we're also really bad at stopping treatment when we should. So when this patient is going the wrong direction, this patient will not get any kind of quality of life whatsoever. We should also be good at stopping care, because we are both because of resources used, but also because of ethical issues. And I think that is a discussion we're not good enough at having. And that should also be basis for studies and basis for guidelines and so on and so forth.
I think it's absolutely true what you're saying. And what about the rehabilitation, when I talk about resilience, we had the experience that many patients, even polytrauma patients, elderly polytrauma patients, if they are can get out of the hospital and they can get to their home, many people go to a nursery home. And I think even elderly people, if we bring them to a rehabilitation center, the result will be much better if we have a good rehabilitation program. Even if that's what I mean with patient tailored even, and even this younger group. If you have a 35-year-old construction worker after polytrauma, even if he's stable and he can walk again, but he has severe foot injury, so it's a totally different situation than somebody who has an office job. So we have to look at in which group you are and what do you want, and then you can focus with your treatment on it.
Okay, and I think that's a very good place to end things, draw the webinar to a close. I hope you've enjoyed it and will join us again in 2 weeks on the 7th of December for the final webinar of 2020, which is going to be on lessons learned in the Beirut port blast. You may remember that in earlier this year, 2,500 tons of ammonium nitrate exploded in a warehouse in the port. Blast was felt about 150 miles away and resulted in more than 175 deaths, with 7,000 people injured. The explosion destroyed the homes of 300,000 people, as well as damage to hospitals and infrastructure. In the webinar, we'll hear from a number of experienced surgeons who had to deal with this in their hospitals. Details of this and all future webinars can be found on the events page of the ESTES website at estesonline.org. In addition to our great panelists, we have a fabulous backstage crew without whom this would not have been possible. So I'd like to take the opportunity again to thank my good friends Diego, Mariani, Alan Biloslavo, Hayato, Geriatric, and Mauro, Zago. And our great panelists, Chris Pape, Klaus Wendt, Richard Kdolsky, Tina Gaarder, Roman Pfeifer, and Radko Komandina. Thank you for joining us. Hope you'll join us again in 2 weeks' time. Goodbye.
Goodbye. Bye.